I hope you're all inspired to get into your communities and make an impact. If you're just joining us, I'm Kristen Sewell, the Director of Content Production for Michigan Health Council. I'm in Lansing at the Capital Area District Library, where they have a section dedicated to adult literacy. There's also an adult literacy coalition located a few blocks away from here. There are many reasons a person may have low literacy, including being an English learner, having a learning disability, either diagnosed or undiagnosed, having impaired vision or cognitive impairments. Whatever the cause, low literacy impacts health literacy and a person's ability to manage their health independently. Our next speaker is Dr. Terry Davis. Terry is a pioneer in the field of health literacy. Her achievements include the development of the Rapid Estimate of Adult Literacy in Medicine, or REALM, and the creation of patient education materials that are used nationwide. Please welcome Dr. Terry Davis.
Hello, Michigan nurses and nurses around the country. I'm Terry Davis, Professor of Medicine, Pediatrics, and the Cancer Center at LSU Health System in Shreveport, Louisiana. Today, I'm going to give you some key information on health literacy as a path to improve health communication and health equity. I've been studying the impact of literacy on health and healthcare for over 35 years. Part of my work early on was developing the REALM and the REALM Teen, which are the first tests to screen for literacy in healthcare. Michigan's shocking health disparities are related to social determinants of health, health literacy, and health behavior. If you look at the pie graph, you will see that only 20% of our health is attributed to clinical care, 40% to social and economic factors, 30% to our behavior, and 10% to our physical environment. So how does this add up for Michigan? In 2020, Michigan, 18% of adults in Michigan had low literacy. It's 28% in Louisiana. Michigan ranked 35th in health, 27th in health system performance, 34th in poverty, low birth weight, STDs, 43rd in obesity and overweight, and 32nd in diabetes and heart disease. So what about health behavior? By the way, all of those figures, if you looked at Louisiana and Mississippi, would be 48th, 49th, or 50th. So y'all have problems, but not as severe as we're encountering. So I'm well aware of all of these problems. What about health behavior? Michigan ranks 39th in percentages of adults with high cholesterol. I'm sure you see this every day. 41st in percentage of adults eating less than one serving of fruits and vegetables daily, 26th nationally in physical inactivity, and 39th in smoking. Detroit has worse indicators than the state. 47% of adults have low literacy. In New Orleans, it's about 50%. 35% of the population is below poverty versus 12% nationally. But look at this disparity. 73% of Blacks versus 14% of whites live in poverty in Detroit. 40% of neighborhoods have no internet. Obesity is 38% in Detroit versus 33% nationally. And physical inactivity, 35% versus 26% nationally. So if you look at this circle icon, you can see that our genetic predisposition has a factor, our behaviors have a factor, but the social determinants of health are huge. And that is all over healthcare now. We must begin to address this because they're large, they're persistent, and they're increasing. So what do we mean? What is social determinants of health? What are the social factors that drive this? Our early life development, how much education we have, the quality of the education we got, being able to get and keep a job, what kind of work we do, COVID exposed a lot of the problems and a lot of the disparities. Having enough food or being able to get food, living conditions, safety of our neighborhoods, clean water, wealth or lack of it, discrimination, racism, distrust of government, which is pretty high in Louisiana right now, how much social support we have, and our literacy and our language. Now, this wheel shows that there are many social determinants of health. I'm going to focus on orange, personal health practices or our behavior, purple, health services, and red, education and literacy. Nationally, cardiovascular disease is much higher among adults with low education and income. It's higher for Blacks than whites. Diabetes is higher for Blacks than whites. Female obesity is higher for Blacks. Cancer mortality is higher for Blacks. COVID mortality is 2.8 times higher for Blacks and Latinos than whites. And hospitalization is higher for Blacks and whites because of COVID. So COVID has really shined a light on health disparities. And health literacy explains a range of disparities linked to COVID-19: age, older age, race, ethnicity, limited education, low income, and rural residents. Inadequate communication and access may cause vulnerable populations to be even further marginalized. These populations have historically poor access to health care, clinical trials, and tend to mistrust medical community. Today, understanding and trust of COVID testing, particularly vaccine messages and statistics, is essential. And a lot of COVID information has to do with these messages and statistics. So what is the role of nurses in COVID-19 discussions, in vaccine, in mitigation strategies, and clinical trials for COVID? I originally was trained as a clinical psychologist, so I wanted to put this in. It's a stressful year for all of us. And the Kaiser Family Foundation has a tracking poll, and they look at all polls done nationally and combine these. And look at this. January of 2019, 11% of American adults said they experience anxiety and depression, but it's about 4 times higher by January of 2021. Suicides are up in the medical community. Pre-COVID, we lost about 1,000 nurses a year to suicide. Last year, almost 3,000 nurses committed suicide, and over 30% seriously considered suicide. Every nurse is just too valuable to lose. So this is a message to take care of yourself and each other. So what do nurses need to know about health literacy? Well, the original definition was it's the ability of somebody to get the information, understand it, and use information and services to make appropriate health decisions. Now, health numeracy is hugely important, and it's been really important for COVID. And it's our ability to understand and apply health information presented as numbers, tables, graphs, probability, and statistics. Think of all the COVID information you are reading in newspapers. Health literacy is also affected by providers and health system, our ability to provide easy to understand, accessible, useful information and services. Nearly 9 of 10, there have been jillions of studies done that found that about 9 out of 10 adults have difficulty using health information that is routinely available in healthcare facilities and in the media. We can't blame individuals for not understanding information that we haven't made clear to them. And it's important to realize that everybody, no matter how educated, is at risk for misunderstanding health information if the issue is emotionally charged and complex. And COVID is, diabetes is, cancer is. There are a lot of health problems that are emotionally charged and complex. I was recently on a National Institute of Nursing Research work group to look at research goals, what they're going to be funding. And they want to improve health equity. That's really important to them. So they were looking for grants that determined conditions necessary for historically excluded populations to have equitable access to healthcare information, screening, and treatment. They're looking for grants that make health information and services easier to understand and access. They're going to have grants that look at self-management education and support that fits the patient's skills, resources, and beliefs. Now there are a lot of digital devices and virtual monitoring, and we've got to make that easy for people. Most people have cell phones, but not necessarily internet or computers or tablets. And they want to initiate and sustain trust-building relationships with communities of historically excluded populations to better understand their specific needs and barriers to healthcare. And I think grants need to begin to partner with Council on Aging, agricultural extensions, churches, community groups. The challenges, as I see it, is that patient education varies widely and may be non-existent. And most people with low income, as I said, have cell phones, but not necessarily computers or internet. There's a big push now for clinical trials, particularly with COVID, but with everything. And there's huge disparities in understanding access and participation among people with low socioeconomic status, racial and ethnic minorities, and people who live in rural areas. You might be interested to know that less than 3% of cancer patients are enrolled in a clinical trial, and less than 10% of these 3% are minorities. The NIH says it's too white. Our research, all our data, all our gene research is too white. Diverse participation is necessary to identify how specific drugs, vaccines, and treatments are most useful for different groups. It may interest you to know that women were not included in clinical trials until the 70s. And so there's a push now that you must include women, minorities, different groups. We need effective strategies to provide trustworthy, understandable information and easier access to clinical trials. So who are the most trusted messengers? Many times the nurse or the nurse researcher is the most trusted messenger. I don't know if y'all remember Alan Alda. He was Hawkeye Pierce on MASH. That was my favorite TV show when I was this age of medical students now. And it was a surgical unit in the Korean War. And he's been hired by Stony Brook now to teach particularly doctors and researchers how to improve their communication. George Bernard Shaw said the single biggest problem with communication is the illusion that it's taken place. Alan Alda says communication doesn't take place because we tell somebody something. Communication takes place when we observe people closely and get signals that they're tracking with us, that we're on the right track with them, that we've started at a place they're familiar with and track their ability to follow us. He also said something I think it's really important for medical students and nursing students. We forget what it's like not to know something. Also, I recently read a book about the smartest kids in the world and how they got that way. And one of the sayings out of that is humans need to be heard before they will listen. And I think that's very true with patients. There are only 5% of the population in Michigan that's Hispanic, but this is increasing. And 18% of the US speak a language other than English at home. There are 54 million Latinos in the United States. More than a third don't speak English well. Health literacy is lower among groups that have limited English proficiency. I know from working with Hispanic patients that they want materials in Spanish and ideally a language concordant provider and not the telephone. And they want to include their family in health decisions, but not use family as a translator. So here's some tips. Consider language before the patient is sitting in front of you. It's too late then. Is the interpreter prepared? Are they able to provide clear information? Focus on the patient, not the interpreter or family member. And think, what does this patient need to understand and what do they need to take away from this encounter? And remember to teach back to confirm understanding. Don't depend on a head nod. Several years ago, about 20 now, the Department of Education did a national literacy test, and they carved out 28 health-related questions. This was a survey that people knocked on doors of 19,000 adults and gave them tasks. And one of the things that's important about this pie graph, if you look at the red and the yellow, 36% of American adults have basic or below basic health literacy. They may struggle to circle the date on a doctor's appointment slip. I don't know how they are doing patient portals. The basic people have trouble determining when it's okay to drink before a medical test based on short instructions. I know our GI doctors say that sometimes patients arrive for colonoscopy and they've stopped for a burger on the way. And so really it's important for the patient and for the health system for people to understand basic health information, like what time to take medicine based on the label. The other thing to point out here is the dark green. Only 12% of Americans have proficient health literacy skills. And increasingly, you need more and more skills. I'm on an FDA panel, and more drugs are going to switch from prescription to over-the-counter. So how do you determine if this is safe for you, how much you or your child need to take? Those are many literacy questions. Here's literacy by county in Michigan. I know where Detroit is. It's the red at the bottom. I don't know the other county that has more than 30% with low literacy. What you need to know is that literacy rates are double for low-income, elderly, and minorities. These are our most vulnerable populations. So here's a health numeracy test. Vanderbilt did this in their primary care clinic, and I love it. They gave patients this label. You drink this whole bottle of soda. How many grams of total carbohydrate does it contain? Well, look at the label. How many does it contain? How do you navigate that label? What math are you doing in your head? Well, it contains 67.5 grams. But look, only 32% of patients answered this correctly. Now, who are these patients? Well, they were primary care patients. 3/4 had private insurance. That tells me they had a job. 2/3 had at least some college. About 8% read above a 9th grade level, and only over a third had math skills above 9th grade. So one of the take homes for this talk is a lot of healthcare and reading labels and diabetes self-management involves math, and Americans are not very good at math. So Vanderbilt followed this up with a numeracy study with diabetic patients, and just about all of them struggled with food labels. The FDA knows this, but is having trouble figuring out what a user-friendly label would contain. 2/3 had poor estimation of portion size, and research that I have done with obesity, I've learned that most all of us have poor estimation of portion size. We think we're eating less with fewer calories than we're actually consuming. About a fourth couldn't interpret a glucose meter. 40% couldn't calculate carbohydrate intake. I know our patients down here think corn is a vegetable and not a carbohydrate. And 30% couldn't dose insulin correctly. We recently did a study with nurse health coaches in Arkansas working with diabetic patients, and patients had a terrible time with insulin. So it's not surprising that diabetes numeracy skills are associated with self-management, self-confidence, and A1C. I love this slide. About half of US adults calculate a tip, and look at this bill. Supper is $23.54. The tip is $5 and something. The total is $29. So I tell medical students I'm teaching, how many of y'all were bartenders or servers before med school, and how often did you see something like this? It was more common than I thought. 1 in 5 college-educated adults don't know what a higher risk is, 1%, 5%, or 10%, or understand that 0.01 is the same as 1 in 100. And doctors also have trouble with math. So just be aware that math is a problem. So now I want to show you a video. This was done several years ago, but sadly, it is still so true with people struggling with health literacy.
So what you do, you come out of that room, that examination room, with this intelligent woman or man, thinking, God, I hope I don't make a mistake with my medicine, because I did not understand anything he or she said to me.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin, because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4. Okay.
I would give her the 4 to 5, a tablespoon and a half.
So you give her a tablespoon and a half. Can you find where it tells you how many you take? The dosage?
Three a day?
Take 3 to 2 milliliters. And there's something I want to point out. I don't actually read this because I know what it says now. So if I had to sound it out, if it wasn't for I knew it, because I've heard it so many times, I would not be able to read that.
Okay.
Every 3 to 4 hours as needed for pain.
Okay. What's a milliliter?
I don't know.
The medication that was given to her was not explained. Well, we didn't use it.
In fact, she ran out of her high blood pressure medicine, so she didn't take it. She didn't call me to tell me to fill it. So finally I found out that she had not been taking it. I said, Mother, you can't do that. You have to keep taking that high blood pressure medicine.
When you get your prescription, you get all this stuff and just throw it away because my eyes are not that good.
And then it says discontinue. What does that mean?
I don't know.
How many times do you take these thyroid pills?
Once a day.
Okay. Do you take one of each of these?
Mm-hmm.
Okay, so you take 2 thyroid pills.
No, I take one. I more likely got them messed up when I got refilled.
And then, are these stickers helpful?
Nope, don't
No.
even look at them.
Don't even look at them.
And what do you take that medicine for?
I don't know what it's for. He just puts me on stuff and he tells me when I have it. I just take it.
So are these true with your patients? Also, all of them got something from the information, but often it was just enough to mess them up. And that's why it's really important that we do teach back to confirm understanding.
So what you do.
So here's some red flags for looking for limited literacy. One thing I've learned is you can't tell by looking at somebody if they have low literacy or low health literacy. But they may say, I forgot my glasses, I want to talk to my adult daughter, incomplete intake forms. It's really hard to spell the names of a variety of diseases and medicines. People identify medicine by the shape and color of the pills, not by their names usually. Frequently missed appointments, unable to give a coherent sequential history. Not taking medications correctly. The more you take, the more likely you get it mixed up. Asking fewer questions. You have to have a certain level of literacy and confidence to ask the question or to say you didn't understand what the provider has said. And a lack of follow through with referrals. If you have diagnosed diabetes, they may need to see a dietitian, an eye doctor, a foot doctor. That's a different provider, often a different building, a different day. So we need to do a better job of patient communication and support. Less than 1 in 5 patients recall what providers tell them immediately after they've left the exam room. Patients commonly say they understand, but yet be poorly informed about their diagnosis, prognosis, and health care plan. 20 to 30% do not fill the initial prescription. 50% don't take meds as prescribed. Almost 50% with chronic disease stop taking medicines after the first year. if you have high blood pressure or diabetes, you cannot tell that you are benefiting. You can't tell any difference. Clinic visit times and hospitalizations are shorter, and patients may need ongoing support to take meds appropriately, especially after they've left the hospital and may be put on a lot of different medicines. They need support to improve health behavior and sustain it. Medication error is the most common medical mistake. There are 1.5 million adverse events every year, and half of them are due to patient error, inadvertent error, usually persistent error, taking a little too much or a little too little every time. There were over 20,000 prescription drugs approved by the FDA last year. 2 out of 3 leave the MD visit with a prescription. Actually, I think there are so many prescription drugs, and they are increasing, and now over-the-counter meds are increasing. We're spending a lot of money on it. We will continue to have pills. They're advertised all over the place. The elderly, people like me, have more than 5 prescriptions and see 8 different physicians or nurse practitioners or PAs, and 1 in 6 pediatric doses are not dosed correctly. There are over 300,000 over-the-counter medicine, and over 600 contain acetaminophen, which is the main cause of liver failure in the United States. And most labels and inserts are in English only. So how would you take this medicine? We did a study several years ago, Northwestern, in Chicago, and Emory, and LSU, and we gave patients a commonly prescribed drug in primary care clinics. And of the people we tested, 48%, just about half, were reading less than a 9th grade level. They took about 1.25 meds, but almost half didn't understand the instructions on at least one label. 38% with adequate literacy missed at least one label. I don't understand that. I don't know if we're being cavalier or think if it's prescribed, it's safe, or if it's over the counter, it's safe. And most people didn't attend to warning labels like the lady in the video. So then we asked them, show us how you would take this medicine. And the SIG said, take 2 tablets by mouth twice daily. The graph shows in yellow, even if you had low literacy, about 70% could say, well, I'll take 2 pills 2 times a day, but they didn't dose out 4 pills. We published this in the Annals of Internal Medicine, and it was picked up by the BBC, and they interviewed the man on the street in London. Those people were just as confused as the people in Louisiana. Now, they sounded real smart because they had a British accent, but the difference in a teaspoon or a tablespoon or 2 tablets twice a day, for some reason, that's just very confusing to people. So we played around with a new label with a bigger vial. People don't like the wording on the vials of prescription medicines, too little. And so we had 3 panels. And so the panel 1 is for the patient. This is Mike's, it's his glyburide, it's for his diabetes. Take 2 pills at breakfast, carriage return, 2 pills at dinner. And then we played around with schematic. At first we drew little pills, and patients didn't understand what the little doodles were. So it's 2 at breakfast, 2 at dinner. Some people with low literacy had trouble with this graphic, but others with higher literacy, it was easy for them to figure out, I need to take 4 pills a day. These were people in federally qualified health centers in Virginia, about 500 patients. They either had diabetes or hypertension. They were taking an average of 5 meds, and about 40% had low literacy. But look at the bottom table. The standard label, without a nurse, pharmacist, or doctor giving any instructions, about 59% understood the standard label, but almost 3/4 understood what I'm calling a patient-centered label. And look at adherence. At 3 months, the standard label, it was 30%. This is, we did by pill count and pharmacy claim, checked adherence, and about 50% were adherent with the patient-centered label. And I'm telling you this because there's certain things that you could do to make it easier. Here's what CVS has done. Larger print, patient's name in bold so you don't get it mixed up with other people in the house, and then using icons about when you need to take the medicine. So that you can do this, you can make your own handouts and give to patients. If they're taking 26 meds, you may not be able to go over all of them, but you can go over the most important ones. Helping patients manage their health. Do we have a problem here? I think we do, and I think we can do better. Much of the self-management information we give patients has little thought into what we're asking them to do, or if they're able to do it. We must figure out what's realistic and unrealistic for a particular patient and partner with them to make an acceptable and, more important, an achievable and sustaining plan. Here's some ways to improve patient education. Slow down. Recently, medical students at University of Alabama, Birmingham, recorded surgeons, and they found out that surgeons talked at about twice the rate of normal conversation, not as much as an auctioneer, but too rapidly for most patients to understand. Focus on the patient's need to know and do. Avoid medical jargon. Use plain language. Use pictures, teaching tools, pamphlets, brown bags of medicine. To anything concrete can be used to help teach. Limit advice. The more we tell patients, the more they forget. Write brief, take-home information. Attend to their culture, their beliefs, their goals, their willingness to do it. Repeat and summarize, and remember, one of the plain language, slow down, plain language, and teach back are keys to health literacy. And teach back or show back to confirm understanding. I get this information so many times every day. I need to make sure I've included what I need to. Tell me your understanding of what I've said. Put the onus on you. Also, I think it's important to check on progress. Touch points are good, and the literature is full of all kinds of touch points and how they help adherence. Ideal frequency and duration may vary by the patient. Also, we need to be positive and motivating because they're the ones that have to do it. Look at this. We developed diabetes guides and obesity guides that have no numbers in them. And no matter how low the literacy, patients understood the healthy plate. They understood this much meat, this much starch, this much vegetables. They can understand how big a potato, a steak, or a serving of rice should be. Problems with most health information is organized using a medical model, and it's not patient-centered. It's scientific, it's bureaucratic, it's not personal or conversational. It's too long, too much information. The key message is often there, but it's often buried. The illustrations are complex or confusing or don't look like the intended audience. Lack of attention to tone, to culture, to a patient's emotions. I once redid a thing for the state on rape to be handed out in emergency rooms, and it was all about the requirements of the state in starting out rather than we're here to take care of you, we're going to help you. So it's like important to pay attention to tone of what the message is. I also believe that patient education is much better if patients and providers have input into the development and we pilot test it. We got to figure out how we're going to distribute it and sustain it. And increasingly, we need to find out what patients are finding out on Google. Most of the doctors I teach say patients come in and they have Googled something or Googled what they think is wrong before they come in. And it's good to talk to a nurse or a doctor about what you've Googled, but it's important to find out what they've Googled. I love this handout. It's out of University of North Carolina. It's about congestive heart failure. And one of the things I want to tell you is that people with high education still prefer simpler health materials. So how bad is your congestive heart failure? You can tell how well your heart is doing by how you feel and what you can do. So it uses color and illustrations. And if it's bad, if it's red, it has a prompt to call the clinic and has the clinic number. So it's specific, it's to the point. It uses pictures and colors to convey the message. It's not too busy or cluttered, and it's action oriented. We need to be aware of faulty assumptions about patients' need to improve health behavior. Some assumptions are patient ought to change, wants to change, or knows how to change. Another faulty assumption is if the patient doesn't change, we failed or the visit has failed. Another faulty assumption is you're either motivated to change or not. We consult them a little bit. We can maybe move them a little bit. Now may not be the right time. We did a study in New Orleans on obesity, but sometimes the patients, their son was in jail, their grandson had been shot. I mean, they're not going to attend to their diet that week. And the patient is the expert on what they are willing to do and are able to do. Behavior change is most effective if the patient, not the provider, chooses the area they're going to work on, and then they're more likely to own it. Rational arguments and many lectures are not effective or scare tactics. So is this a duck or a bunny? How many of you see a duck? How many see the bunny? Well, it's up to us as providers to see both the duck and the bunny. Because if we see the duck and our patients see the bunny, we're not really communicating. Many things have many sides. So here's a framework to help patients manage their health. Ask, is there anything you're willing to do this week to improve your health? Then wait, don't jump in. They're not used to you asking, they're used to you telling. Briefly review patient education if it's appropriate. Underline things, highlight things. Coach the patient to set goals and create an action plan to change behavior. Baby steps, not do 5 things. I'll walk around the block 3 times a week after my show on TV. Assess their confidence. On a scale of 1 to 10, how likely are you to do this? If it's not at least a 7, redo the action plan so it's very achievable. Teach back to confirm understanding, write it back, and frequent touch points will help improve compliance. You're doing that to check on their progress to help them redo it. You serve as a partner, not an expert in helping patients change their behavior. So here's some health behavior change tips. Think about what you're asking patients to do. The more concrete and specific, the better. And give the benefits. Why is it in your best interest or your child's best interest to do this? Consider harm reduction rather than all or nothing change. The deal is to get them to move the needle. Make it interactive. Ask patients what they're willing to do this week. Behavior change is most effective, as I said. This is research out of Stanford that has proven true over and over again. If the patient chooses what they will work on. Assess their confidence. Their buy-in is essential. If they don't have the buy-in, they're not going to do it. It must fit in the context of their lives, family, and culture, and check on progress. So I'm going to talk for a few slides about inpatient communication. I was part of a national study. We did 40 focus groups nationally. And what we found out is patients and caregivers said inpatient communication can be supportive, transparent, actionable, empathic, respectful, timely, collaborative, purposeful, or it can be frustrating, unpredictable, conflicting, one provider saying one thing, another saying another, condescending, unilateral, hurried. So what makes it good? Well, what patients and caregivers said is, when we provide emotional support and empathy, it fostered trust in the whole team and in the care we provide. They like providers who sit down, who don't appear rushed or distracted. We all are rushed, but how do we walk in and convey that that patient has our full attention? We are emotionally present. Connect with patients on a personal level. Call them by name and helps them feel known. Collaborative, being involved in medical decision making. Nothing about me without me. Patients like it when they're encouraged to talk and feel comfortable asking questions, including questions about the appropriateness of the care, the test, or the drugs. And we've got to anticipate their needs at home. Often when we discharge patients, they need skilled nursing care at home, but the spouse or the adult child, do they have the skills and the equipment to do that? And then people always wanted to know, if I have a problem or a question, who do I call and how do I get a hold of them? We mailed out almost 8,000 surveys 51 days after discharge. Most of these patients were Medicare patients. This was mostly white bread patients because we could not, hospitals were being bought up by other health systems, and there was such a change that this was disproportionately Kaiser, and that is a weakness. But patients who reported that providers conveyed trust and used plain language, tailored care planning, did med reconciliation, provided easy to use care transitions and post-discharge outreach, what to do when. They had better mental health, greater participation in daily activities, and less pain. And the hospitals liked it because there was a lower likelihood of a 7-day ED visit or a 30-day readmission. First impressions are important, and patients size us up pretty fast. And they look at posture, facial expression, voice tone, rate of speech, touch, and space. Of all of these, voice tone may be the most important for a provider to slow down and have a warm tone of voice and create a zone of intimacy. So here's some communication takeaways. Sit down, focus on your patient, engage them, listen to their concerns and acknowledge them. One provider told me, if a patient tells me something twice, I know it's important and need to respond to it. Slow down, be emotionally present, authentic. Use a calm, warm voice tone. Be respectful. Include family member when appropriate. Think, what are you asking patients to do? Be concrete, specific. Give the benefits of doing that. When we're concise, to the point, actionable, use plain language, it's easier for people to understand and recall. Limit the information, use pictures or icons, brief, take home, handout, and use teach back to confirm understanding. So what's our bridge to action? What practices could we implement to make health information and healthcare easier to access, understand, being mindful of social determinants of health? Now we're going to open it up to Q&A.